Hi, I'm Rick Barron, and welcome to the next segment on RAF5. And today I wanted to talk about pyridostigmine and in the treatment of myasthenia gravis. Here is a brief table showing our various therapies for myasthenia gravis, and I really think the first line in any patient should be the use of cholinesterase inhibitors, and today really all we use is pyridostigmine. But what about the history of prostigmine, also known as neostigmine? Well, Mary Walker, as most know now, was the first to really use acetylcholinesterase inhibitors for the treatment of migraine. She reported this in The Lancet in 1934 using physostigmine, an injectable form. And here's a patient of hers showing improvement of ptosis and facial expression. Mary Walker was a house staff officer, and she was actually came up with this idea and talked about it with her mentor, Derek Denny Brown, at the time, and he supported this. And this is the next paper she did, where she used injectable prostigmine. And you can see once again in these three patients with myasthenia the dramatic effect. So for almost 20 years, prostigmine or neostigmine was the treatment for myasthenia gravis, and it was made into an oral form, and so patients were taking it orally. And in the mid-50s, pyridostigmine, which also known as mestinon, came on the scene, and I could find a handful of really interesting papers on this by the leaders of the myasthenia gravis field at the time. Dr. Osserman, Dr. Westberg, Dr. Tether in Indiana, and Dr. Schwab in Boston all wrote papers, and in the Osserman, the Westberg, and the Tether paper, what they did is they had these large clinics of patients with neostigmine, and they converted them to pyridostigmine, and they looked to see if they maintained their benefit, and they also asked them did they think it was better or worse than the neostigmine. They asked the patients, and basically, as you can see in the summary of these papers, most of the patients were able to be converted to pyridostigmine, and most of the patients preferred it. Now, the Schwab article was interesting, the one that came out in New England Journal of Medicine, and he said there was no advantage in his clinic population of pyridostigmine to neostigmine, but that was an outlier paper. And so since then, since 1955, pyridostigmine has been one of our first-line treatments for myasthenia gravis. The generic name is pyridostigmine and the trade name is mestinon. So these are my caveats for the use of pyridostigmine in myasthenia gravis. It should be your first-line treatment, but don't expect or use too much. If a patient is on 60 milligrams 3 times a day or 4 times a day and they still are symptomatic from their myasthenia gravis and have signs, it's time to move on to immunosuppressive therapy, and that's usually prednisone. But there are other options as well. Generic is now available, and that actually is less expensive for patients, and so I usually prescribe generic pyridostigmine. I tend to avoid the time-release capsules. I think the absorption seems to be erratic. It gives patients larger doses of pyridostigmine than they need. If the patient absolutely wants to take pyridostigmine or mestinon time release, I'll let them do that, but I prefer to use standard 60 milligram capsules. If they have GI upsets such as diarrhea or cramps, I will put them on hyoscyamus sulfate with each mestinon dose, so usually up to 3 times a day, the 0.125 milligrams. So while there is no randomized controlled trials of pyridostigmine for myasthenia gravis, we do have what sort of looked like in the 50s comparative effectiveness studies. But as Dr. Gronseth made a point with regard to prednisone, I think the size of the effect of acetylcholinesterase inhibitors in myasthenia was so dramatic in the 30s and 40s that this is probably another example where you don't need a randomized controlled trial. Pyridostigmine is still the only FDA drug approved for myasthenia gravis. And I want to make one more point, and that is that cholinergic crisis really does not exist in the modern era. So we can usually take that off the concern sheet on a patient with myasthenia gravis who's worsening. Why is that the case? Well, cholinergic crisis was really described in the 50s in the early reports when they would use up to 4,800 milligrams of mestinon, which you can see in the tether paper. They would use massive doses of acetylcholinesterase inhibitors because they had no other therapy for myasthenia gravis. That was the era when we saw cholinergic crisis, but in the modern era, it really is not an issue on the doses of pyridostigmine that we use today. So thank you for listening to another episode of RAF5, and I hope you find this information useful in your clinical practice and the management of your myasthenia gravis patients.